thanks for coming. I'm Sarah Ranazzi, I'm a member of the board, and it's my pleasure to introduce Ron Stock. He is a geriatrician and clinical health services researcher at OHSU Family Medicine, and did his medical school at University of Nebraska and residency at University of South Carolina, University of North Carolina, Chapel Hill, right? Both?
Medical University of South Carolina.
Thank
Yes.
you. And is also an associate professor at the Department of Human Physiology.
I have an appointment at University of Oregon too, yes.
And he enjoys hiking, running, and just traveling with his family. He is here to talk to us about team-based care, and he has indicated that he has no relationships to disclose relating to the subject matter of his presentation.
Thank you. So, well, thank you for that too. There are some handouts back here when you come in. Hopefully there'll be enough. If there aren't, let me know and we can get some. I can get some to you or send them to you by link. I'm currently at the Department of Family Medicine at OHSU. Joined them almost 1 year ago. Where after I was in Eugene and practiced in Eugene for 23 years, and was in private practice, and then joined Peace Health Medical Group and did a number of things. And one of the areas of interest was to redesign the clinical delivery system for vulnerable and frail elders within the community in Eugene. As part of that, became very interested, this was about 15, 17 years ago, became very interested in teams and the importance of actually working together to manage some very complex problems. And as you all know, things just aren't as easy as they used to be. And it's a bit more complicated, and the idea of us managing this just by ourselves is almost not realistic anymore in order for folks to get the right care. So what we're going to talk about today is what we've learned over the last 15 years. I'll share that with you. We'll see if this works. Yeah, so we're going to talk a little bit about getting on the same page. So I tell folks that this is really Teams 101. I've spoken to a number of folks, so I don't know if others have heard this before, but we're really going to talk about getting all on the same page about what language we use, because that's really important. As we ourselves understand what teams are, but also as we communicate this to our staff and the people we work with so that we're all on the same page. So we're going to talk about some of the language we use and what we mean. We're also going to talk about what are the key attributes of teamness. I use teamness. I don't think it's made it to the dictionary yet, but I'm hoping that maybe in the next 10 years that teamness will actually be used. But we'll also talk a little bit about what we've learned and what other practices have learned about what makes a difference in developing teamwork and team-based care. And then we'll talk a little bit about the issues. Now, this is not really, it's a presentation, but it's also a workshop. So part of that is an expectation that we're going to have a dialogue. There's going to be some interaction, and so I'll be expecting you all to participate in this. So this is the first part of the participation. So one of the things I want you to do, let's talk about teams. And we frequently think of sports teams as being the metaphor, the analogy when we think about teams. And I'll just share with you that I've found that using mental images like sports teams and orchestras that you'll see in a minute is a really good way of getting your staff engaged in thinking about this. And there's actually a lot of literature outside of the medical literature about the importance of us all having a mental image or a mental model in which we operate. So what I'd like to hear from you is, when we think about, let's talk about a football team. So we have a football team here. What are the things, the aspects of making a really good, successful football team?
Common goal.
Okay, so that is?
Winning.
Winning, right. Usually on Saturday, sometimes on a Sunday. But so there's a common goal of winning at the end of the week or whenever. What else?
Huddle.
Huddle, yeah, they usually always get together between plays, and except unless you're the University of Oregon Duck and they don't believe in huddles, which may be a little different mental image, a mental model, but be fun to play with. So yeah, so they have a huddle. What else?
Good players.
Good players, yeah. And so there's sort of the expectation that you're going to recruit people that are kind of at the top of their game, right? Or at least the best that are going to be the best at the top of their game. What else?
Coaching.
I'm sorry?
Train together.
Okay, so they usually spend some time each week training together, don't they? Okay? And they usually practice. And they practice virtually every day for a few hours for the goal at the end of the week, which is winning the game, right? Okay, what else?
Clipping.
What's that?
Clipping.
Clipping, okay, Dr. Wopat, you're going to have to, that's the first one. So you're going to have to explain that to me. Clipping, okay, all right. We all, yes?
Holding.
Holding.
Slashing.
Well, you know what, there are penalties, aren't there? Sometimes we make mistakes in teams. Cohesion, okay, and in what way? How do good teams, good football teams here, how do they stay cohesive?
They see themselves as a part of a bigger whole.
Okay, and what do they do? What do they do to do that?
They communicate, they interact, they
Rely on each other.
rely on each other.
Okay,
Well, they make plans.
okay, what kind of
They have
plans?
plays. that
Okay, they have
have
plays, all right, good.
Sort of figured out ahead of time, and so each person knows where they're supposed to be on the field at
Yeah.
any given time for a play.
Okay, so there's usually a playbook, and everybody's read the playbook. And generally the guards know what they're supposed to do for a particular play. The halfback knows what they're supposed to do. And everybody has their role in mind, right? Okay, what else?
But they have a leader
Okay,
for
and?
the team. They actually have two levels of leaders.
Okay.
They have a leader on the sidelines, and they have a leader on the field.
All right, so there's usually a quarterback who is maybe calling the plays. And generally then there's usually a good coach. I mean, frequently good teams have good coaches. What is it about the coaches? What are they, some characteristics of those?
Strategic planning, long-term.
Okay, they're looking into the future.
Get their best behavior out of their players.
Right? They're monitoring behaviors of the rest of the team, everybody else.
They know the strengths and the weaknesses of the players.
They know the strengths and weaknesses. What else do they do usually on Saturday night or Sunday after the game? They review films. They review and what are they looking for? What are they doing? They're looking to improve. They're looking at ways, what they did right, what they did wrong, and then they usually provide that feedback to the rest of the team, right? About how they're doing, and then preparing for the next week, right? Okay. So some other usually you need a good field to play on. You need a place to play. You need fans, alumni, backup. You usually have lots of players on the sideline that can come and go to help fill in when somebody else is either injured or they need to do something else. So there are a number of things. What about this? It's another sort of a team. What makes a really good orchestra or an ensemble?
Using the same music sheet.
Yeah. Okay.
Leadership. Being on the same
Okay,
page.
so having they all have music. In general, they're reading from the same music, but some of the instruments may have a little bit of different music than others. Okay, and I think somebody said what else?
Orchestrated.
Okay.
They have a leader.
So there's a conductor, there's a leader there.
Harmonized.
Harmonize. How are they harmonizing?
Well, they're just blending
They're blending. How do they blend?
They listen
their
to each other.
skills.
Yeah, okay.
They
Their
listen to
skills.
each
They're
other.
listening to each other. Okay. They understand, when they should be playing, whether they're playing louder than the other or whether they're in harmony with others. What else?
Practice.
Practice. Yeah, they practice a lot for that one period of time. Anything else? So these are some mental images that you might think about playing around with your staff with, okay? Thinking about this. I'm assuming that many of you are starting to make some connections maybe with healthcare and what you do in your own day-to-day practice. I'd be remiss if I didn't somewhere along the way put in a formal definition of what teams are. So here it is, the Institute of Medicine, which interestingly enough has become a really big deal to the Institute of Medicine. So I sit on the Institute of Medicine board on team-based care, and we just finished writing a white paper, and we're about ready to write a discussion paper on patients on teams. So the question becomes, well, where does the patient fit into these mental images, these mental models? But the Institute of Medicine, team-based healthcare is a provision of health services to individuals, to families, and or their communities by at least 2 health providers. You need at least 2 people, okay? Who work collaboratively with patients and caregivers to the extent that people want to be worked with to accomplish shared goals and across settings to achieve coordinated high-quality care. So so share with me a little bit your examples of where you've been part of a highly functioning team. And I would say, you know, you could talk about a healthcare team, or you could talk about some other team. And what was it that really made them high functioning? What's your experience?
National Disaster Medical Team,
Okay, tell me about that.
35-member team made up of physicians, nurses, paramedics. Most of the physicians are emergency physicians or somebody particular. We have security, we have pharmacy, it's a multidisciplinary team that effectively goes into disasters and provides care without putting a burden on the local community.
Okay. Other examples of. Yeah.
I'm David Sims, I'm a med student, and not that Rick Wopat can't talk for himself, but I'll talk about spending some time on his team down in Lebanon. And it's a much smaller team of Dr. Wopat, his MA, there's a nurse care manager, the front desk folks, and I spent a couple of months there and watching how they were able to communicate as the day went on and the needs of the day changed. There was sort of this constant communication and rearrangement of duties and communication about who was doing what that was really effectual. And I think maybe the most remarkable thing about the team was that they ate lunch together every day. Nobody was obliged to. It just happened.
Yeah. So they probably liked each other, and they also communicated. So a couple of key pieces. Anybody else? Any highly effective participation in teams.
What do they eat for lunch?
Pizza every day.
So I'll tell you about my experience. And this is about 15 years ago. We started a clinic that was really focused on vulnerable elders and frail elders in the community. But this is Krista. So whenever we think of teams, I think of the North Star as the patient. And what I would say from Krista's perspective, so that when we think about teams and who's on the team and what is the team, we frequently think about it, realize that we think about it from our perspective, from our mental model of what it is. And I would just ask you to think about it, well, what would the patient think their team was? Who is the team to them? And what I would say for Krista, who was someone who moved to the state from the East Coast to be closer to her daughter. Initially, Krista's team was her physician and the MA, because that's what she needed. She had some high blood pressure, some diabetes, but really her interaction with the healthcare, if you asked her, she would say, oh, my physician and maybe the receptionist up front. But what she would also say is that she would assume that there's sort of a team in the practice that is able to make sure that I get an appointment, make sure I get there on time, that I'm assuming that there's a group of people that have been well trained, that have been on a playbook, they know what the procedures are in the community. But from the patient's perspective, they may not see that, but from our perspective, we think about that as being really critical to making sure that the practice runs. Krista unfortunately had developed a tumor in her spine. And all of a sudden, she needed more than just the doctor and the MA. She needed the pharmacist, Brad right here, who helped manage her diabetes, had lots of one-on-one visits and actually helped manage it through some protocols that we had developed. The physical therapist who was actually part of our team and joined us every week in our care planning, and we had an understanding about what kind of relationship we had with the physical therapist, even though he wasn't part of the clinic. Our licensed social worker, because now Krista needed some help with accessing resources in the larger community. So all of a sudden, when the patient needed it, there was another group of people that were communicating with each other that became a team. So the point is that it's not, teams, we're all part of teams, and we are sometimes part of smaller teams and other times larger teams. We may be part of teams in the groups of people in the hospital, we may be in our practice, we may be parts of groups of people in the larger community. So it gets actually kind of quite complicated when you think about all the different teams that you might be part of. When the National Demonstration Project for Primary Care Medical Homes, Ben Crabtree and others sort of found 6 themes that I think really relate to the development of teams and what we think really worked in those practices that were really able to redesign their practices over time. And that is, number one, is how prepared are your staff? Do they have the adaptive reserve or the capability to manage the changes that may be necessary in the practice? And it's really important for all of you in your practice to keep your finger on that. That the developmental pathways of developing teams or developing a medical home really is going to be varied from practice to practice. I wish I could come in here and just give you a recipe that this is what you need. This is, if you just did this, this cookie cutter, then everything will be fine. But it really is much more individualized than that. There are some key components and key pieces that you're going to hear about, but it really does come down to the sort of the culture and the interactions that you have with your own staff. And particularly motivation. You have to want to do this, okay? Most of this work is not just sticking your toe in the water. If it gets too hot, pull it out, okay? You need to decide whether this is really the kind of work, this is the kind of culture you want to develop or not. And the larger system, whether it's your own medical group or the hospital that you might belong to, can either help facilitate this or they can get in the way. Those are key pieces to transforming your practice. And that it's going to require us to think differently, have different mental models, thinking about practicing, thinking about what is our goal at the end of the week, and do we have a playbook that people are all on practicing off of the same or out of the same playbook. And that it really practice change requires lots of different roles and people understanding what those roles are within the practice. So, what is a team? We use lots of, we use a number of different words. And I just want to take a moment here to talk about those different words. So, multidisciplinary. So, we might walk onto a hospital floor, or we might be in this room. There might be folks that are from different disciplines, but does that make us a team? But that's a multidisciplinary. You might say that the unit in the hospital is a multidisciplinary unit because the surgeon comes on the floor and the primary care doc or whatever, but that's just a multidisciplinary. That doesn't usually mean that they talk to each other, right? So when they start talking to each other and communicating and sharing patient information about the care of the patient, you then become interdisciplinary. And it requires at least 2 people to talk to each other, right? But a third team, a higher level, higher functioning team, are really what are called interdependent teams. So, and a word that has emerged is called transdisciplinary. And what we're talking about here is that you know that when someone comes in, for example, requiring a pneumovax, your nurse or whoever is going to do it. That I am dependent on them to do the right thing because we've talked about it, we've agreed on a process, this is the protocol, and it's going to get done. So I think you could probably think of a number of different ways in which you might do interdependent care. Maybe around diabetes care, you have a protocol in which Patients are identified, they're contacted, they're brought in, they may have certain requirements, but it requires 4 or 5 people in your practice in order for that to happen. But they all depend on each other in order for that to happen. That's really the sort of the transdisciplinary interdependency that's important in more high-functioning teams. The second thing I want to bring to your attention is distinguishing between what's teamwork and team-based care. Because there's a lot of, this word's being thrown out a lot, or these words are. And I want you to think that teamwork is really, it's a relationship-centric. It's all about us in this room relating to each other for a common purpose. All right? It's about our relationships. How are we going to communicate with each other? How are we going to interact with each other? So it may be the staff in your practice. It may be the MA, patient access specialist, the physician or clinician. And it's just, that's teamwork. It's relationship-centered, as opposed to team-based care, which is really around the process. And it's a specific approach in how you deliver that care that is based on facilitating teamwork. So to me, the basic, you can't really do team-based care unless you focus on the relationships with each other within the practice in order so that you can come up with the processes and the delivery system. So, focusing on the teamwork piece and on the relationships is critical, and in fact needs to be probably is the foundation in order to develop these other processes. But that's sort of the difference between the two. Does this make sense to folks? I'll assume so. So, and so when you think about your teams, that it really requires sort of 3 different levels. It requires us as individuals. We all come to the team with our own background, our own biases, our own way in which we communicate, and the way in which we might interact with folks. That's our individual part that we bring to the team. But putting us into the room as individuals doesn't make you a team. Doesn't necessarily make you a team. That the team itself has attributes. That the individual parts, that the sum of the parts is greater than the individual parts themselves, okay? And that there are characteristics of the team that are important. And that the team usually exists within a larger organization, and that all 3 of those really need to be work together in order to make that work. So some individual teamwork skills. What are some ideas of good individual teamwork behaviors? People?
Listening.
Listening, okay. Yeah.
Consulting with your team members.
Okay, communicating, consulting with your team.
Innovation.
Okay, innovation.
Brainstorming.
Okay.
Cooperating.
Cooperating.
Trust.
Trust.
Anticipation.
Anticipation of.
What needs to be done.
Okay.
Being able to think ahead and not function just from rote, but have a global concept of what's going on.
Right, okay. What else? What are some other individual?
Understanding.
Understanding, okay? Understanding.
What the job is, understanding what your role is within that function.
Patience.
Patience, as in P-A-T-I-E-N-C-E, right?
C-E.
Yeah, good.
Flexibility.
Flexibility, great.
Trust.
Trust, good. So, listed a few that have actually been studied, okay? This is actually, so we all come with our own personal skills and our own behaviors, all right? And some of us have had training, or some of us may have had training working in teams and others not. And you need to realize that when you work with everybody else. Communication, good listening. Need to be able to consult with others, need to be able to communicate. And one of the important things that we've discovered is that we all sort of have our own styles of communication. And that you might be someone who wants to be communicated during the day, say in a busy clinic schedule, you know, just leave a note on my desk and I'll get back to it at the end of the morning, and that's how I want to be communicated to. Don't bug me, okay? Don't bother me. And others say, knock on the door, interrupt me. If somebody wants to talk to me, I want to talk to them. So we all have different ways in which we want to be communicated with. And what we've sort of discovered is that once people know that, there's a lot of less conflict and less angst about how people communicate. And so being able to share that with others is important. Team leadership. By virtue of what you all do, you are team leaders, whether you like it or not, okay? And frequently in your staff look to you as team leaders. One of the things that we discovered very early on in our teams was that we thought that we could just sort of flatten the hierarchy so that we could kind of make this a democratic process within the practice, so that everybody had a chance to contribute to it. You know, it's the old good Oregon way, right? So, but we were told by our staff very early on, they said, well, like, who's in charge? Okay, we want somebody in charge here because I need to know what I'm supposed to be doing. And the staff said, we need leaders. They made it very clear to us about that. We don't want you to go away. we want to know. And I think that one of the skills that we frequently don't address in our training and as leaders is that we're sometimes leaders and we're sometimes members. And that there's some skills with the ability to actually go back and forth between those two roles. And the importance of understanding that sometimes I'm going to be in a group where I'm going to be a member of that team, and my behaviors and my role there may be quite different than if I were the leader of that group. And so it's important to be able to identify those two roles and be able to go back and forth with that. Mutual performance monitoring. Anybody know what that is? We were just talking about it. Albert was just sharing that with us. Watching what everybody else is doing. So I think an example might be if you were putting in a central line and you skip a step. And your partner next to you is watching you do that and saying, hey, wait a second, you just skipped a step. Or your partner may see a patient where there was some question about whether you were doing the right thing or not, or whether the right medication was prescribed. The idea of mutual performance monitoring is that my expectation is that my partner, my staff, whoever they are watching what I'm doing, and that they're empowered to stop me or ask me about whether that's the right thing to do or not. And that in highly efficient and effective teams, this is very much a part of that culture, is that mutual performance monitoring and watching that. Yes?
It's kind of like what Gideon's was saying about the patient-centered observation forum, where you and your MA can observe each other and then give each other feedback on how you interact with the patient. And are you saying things from your directive or with their perspective in mind, and then giving specific feedback?
Right. So you might ask your MA sometime if they were in the procedure, what do you think about how that went? You know, is there anything I could have done that would have been any different? Or, you know, beginning to sort of check in with that. And then also sometimes being really clear about how you're going to manage certain patients, and having some protocols around that. And the agreement in the clinic about, well, if you're not going to follow those protocols, then somebody's going to call me on it, or at least ask about it. Very early in practice, my partners and I had 2 other partners. I was in a 3-practice group. We agreed that once a month we would go have lunch together, and we would be disgustingly honest with each other. Okay? That was one of the best things that I ever did as a young physician, was to be able to sit down and have lunch with 2 of my colleagues, and we would talk about situations or times which we were not quite sure the other one had done the right thing. And it was all about sharing with each other kind of our perspective about that. But that's really a high-level skill for teams. Backup behavior. About that. An example of that maybe in your practice. Yeah, Keith.
Just fill in for your partners when they aren't there.
Yeah. And maybe watching the schedule, so you know that your partner needs to be out by 3 o'clock to go watch their kid's soccer game, and you see that they're really busy. Well, you have a couple of openings, and you say, well, maybe I could see a couple of patients for you. What can I do to kind of help you? And sort of on the hospital side, maybe getting 3 or 4 admissions or whatever, and you say, okay, that I can't do anymore, and you might volunteer to take the next admission. But it's that kind of idea that you're watching out for your folks in your team, and that you're there, you got their back. Okay.
So do you answer the phone if there's nobody around?
Yeah.
Doctor?
Okay.
Yeah, so it's not unusual for me. So if my nurses are busy, I'll go room my own patient. All right. Part of it is because I like to be on time and I don't want to get behind, but I also am watching what's going on. I'm finished. I'm ready to go. There's a room that's open and she's busy giving immunizations. Okay, and I know it's going to be another 5 or 10 minutes. I'll walk out there and I'll just say, hey, come on in, and I'll get started on that. We'll do the vital signs at another time or whatever. But that's an example of kind of the backup that we're all in it there for number one. The North Star is the patient and making sure that they get what they need. Adaptability, somebody talked about flexibility, but that's another individual teamwork skill that's really important. What we do is completely asynchronous, okay? It would be nice if we could just walk into the airplane and do a check-off list and everything's good and we could take the plane off, fly off with the airplane, but that's not the kind of work we do. Our work is asynchronous. We don't know what's going to happen next after we give them a prescription. We usually do, but they may end up in the emergency room, or they may not take the med, or there are a number of things that just don't happen according to protocol. And we need to be able to be adaptable in order to make that work. So I just want to make a couple of comments about leadership and the importance of leadership, because you all are leaders here. And I didn't want you to go away without really understanding the importance of your role, which I suspect you already know that. But that there's different kinds of leadership. And I'm a real believer in the facilitative type of leadership, which really promotes an environment of learning. That creating a learning environment for all your staff, whether they're receptionists or MAs or whoever they are, and the importance of helping them reach their top potential. Creating an environment where they can be successful and things can be accomplished. You need to be clear about practice change. This is not a place where you're ambivalent about whether you want to become a medical home or not. Your staff is looking to you as the leader of that. And to make sure that you've got the time and space that's needed to make the changes to improve care, and that's really challenging, particularly when you're trying to see patients and provide patient care. But I would say that there are some behaviors that I think help promote this. And what's not on here is one I always put on. I don't know why this slide doesn't have it, but number one is show up, be present. Okay, be on time and show up. All right, that does not go well when the leaders don't show up, and that's really critical. The unambiguous support. I mean, this is again, you need to be clear about this is the kind of culture, this is the work that you want to do, and the importance of leadership is really setting direction and letting your team talk about and help define what the means are to reach the goal that you have for them. Okay, because they need to be empowered to do that. Supporting managers, I think one of the things we discovered very early on is that the manager usually, and you may have different kinds of setups in your different clinics, but there's usually an administrative person who really takes the brunt of everything. They're really the sort of the wall that if there's any personal or professional issues that are happening with staff or flow or from patients, they're the ones that are kind of the first tier. And this is the group of people that you will probably have the biggest impact on. Tying yourself to their hip and supporting them and helping them coach them about how to be a good team manager is absolutely critical. So that when there is potentially a staff issue, that instead of having the manager be expected to solve the issue, the manager might actually approach it from a team approach and say, I want you to talk. They may facilitate the two people to come together to resolve it themselves. Or they may bring them together into the office if there's a conflict, and they begin to coach each other. So the manager becomes empowered as the team coach. All right, and I think that we've overlooked the importance of training and coaching managers, and I think this is a really critical part. We talked about creating a learning environment, maintaining boundaries. There's some things, you know, like one of your staff people picking up a patient and bringing them in or taking them home, maybe crossing the boundary a little bit. You need to be really clear about what those boundaries are and clear with your staff and others about that. And then finally, inspiring, rewarding. We don't do enough of that in medicine, in my opinion. Our staff loved ice cream cakes. Wopat's, you know, he feeds them lunch every, you know. So, you know, inspiring and rewarding is really, really important, and that will pay off. So how do you develop teams? Has anybody been involved with team steps here? Okay, we've got one person. So surprisingly, there aren't a lot of programs to develop teams in healthcare. And I'm not quite sure why. Team Steps actually has been around for about 10 years. It was developed through ARC and the Department of Defense. So it took the military understanding of teams, of which they've been doing it for decades. And then the ARC, AHRQ, their patient safety work that was primarily done around patient safety in the hospital, and they put a program together called Team Steps. Unfortunately, Team Steps was really hospital-centric. Very much safety-centric and hospital-centric, and so it didn't really generalize into the outpatient setting very well. But in the last 3 years, fortunately, they got that after enough of us kind of gave them that feedback, and they've just recently come out with a program that's designed specifically for the ambulatory setting, and I think it's better. But you can Google Team Steps, TEAMSTEPPS, and get a flavor of that. What I'm going to offer you here is actually a program that we developed over the last 10 years based on the previous 10 years of experience and what we think has worked in developing teams. And we called it the Team Intervention Bundle. I thought that was kind of cute because everything else was a bundle. You know, why not make a team development a bundle? That these are sort of the key components in which, if present, gives you a higher percentage chance that you're going to develop a team. Number one component is the leadership commitment. We talked about that, but quite frankly, when I've gone in to consult with practices about becoming teams, if I'm not convinced that, number one, there's an organizational support for this, and number two, there's a physician champion. Usually, I would say a physician champion. There are some practices where you might be a nurse practitioner or a PA, but I would say that the physician role in general is a pretty powerful role, but that unless there's somebody there to do that, I would usually recommend that you kind of wait on getting too involved with this because it's really a critical piece. The second is to begin to define the team. Who is the team? I would say that most folks have never really kind of sat back and thought about, well, who's on my team and how many teams do I have? What I heard some people talk about is that, well, you know, really my team is my nurse and myself and maybe my receptionist, and now with the medical home I might have a nurse care coordinator. But they also practice in the same building with maybe 3 or 4 or 5 other physicians or clinicians that all kind of share each resources. So who's the team there?
It really depends.
Yeah.
How you organize it.
So the patient would probably say it's the physician and the MA and whoever they have contact with. The group might say, well, you know, I share receptionists, we share maybe lab, and nurses kind of go back and forth between practices. We kind of know who the patient population is. So what I would say is that you probably have kind of the larger care team, and that this care team is usually folks that know the practice, and it might be several clinicians and physicians. And then what's another sort of a new word that's been out there that Tom Bodenheimer from UCSF has coined for the VA, it's called teamlets. And the idea that there are these smaller groups of 2 or 3 more practice and maybe clinician or physician specific that are their own little team, and they may have their own little culture even within themselves. But I think being able to understand and being able to define that and being clear with that with your staff, I think is an important piece. I think having understanding who's in charge, having meetings, so we talk about practice. You know, it's hard to become a team unless you're in the same room and communicating with each other. And creating an agenda. Generally, what I recommend is that you keep these meetings and these agendas as being within the context of patient care. So we always start off the meeting with either a story about a patient encounter or something that happened, or we talk about the care plan for a patient. And it's always started that way. If we don't get anything else done, at least we help somebody, okay? So, but I think it begins to ground this, again, with the North Star, and that you understand that this is really about our working together around what the patient needs or what the family needs. So that the other agenda items tend to be performance monitoring, so providing quality information about how you're doing with your diabetes numbers or whatever. And then the third sort of general topic has to do with operations, okay? We have this new policy in place or whatever. This isn't working so well, let's talk about how we're gonna deal with that. The third is, it's hard to know how you are a team unless you know how many of the attributes or how much of a team is there. So we developed a measure about 15 years ago called the Team Development Measure. And you have that as a handout. In a minute, I'm going to have you just kind of go through that. But we use this measure, it's a self-reported measure from the perspective of the people in the team about how much teamness they think there is there. And we then provide that back to them, and they begin to talk about how they could improve that. So it's really a quality improvement tool to help them develop as a team. The fourth is when we asked our staff what they thought was absolutely the most important thing for them to become a team, every one of them told us it was the time that we spent helping them communicate with each other. It was all about communication. That once they understood how they could communicate, how you wanted to be communicated to, it was usually the physician, because they were finding frustrations with not being able to communicate, but once they understood that and were able to communicate with each other, then they felt like they could get work done. And then the final is that, again, you have to get together in the room in order to practice. It's sort of like the football team or the orchestra or whatever. People need to know what the music is, what the playbook is. They need to know what their roles are. And that I think that one of the ways in which that happens is through either through patient care conferences or through your huddles. How many people here are doing huddles before they start practicing? Or they're, okay. And huddles tend to be quite diverse. One of the rules is the huddle lasts no longer than 5 minutes. You kind of go down through the list. Sometimes they last longer, but you can kind of develop that yourself. But that's one way, within the context of patient care, you're actually practicing all these things, okay? They're beginning to understand what their role is. They're beginning to understand what you like, and so on. So it's a practice experience. So I want you to take a look at the team development measure here for a couple of minutes. And I want you to go through some of those questions. We're going to have just a few minutes here, but I'd like for you to read through some of these. And I want you to think about, so I want you to, in your own mind, think about who your team is, okay? And I want you to focus on your clinical team. And think about who they are and who are those members, and then answer those questions based on that. I'll just give you a couple minutes. No. There you go. That's on me.
Is this the one we did for the profit?
Yes.
All these talks getting recorded?
You're an experienced...
We have 100% agreement on this.
Yeah, you had 100% agreement on it, right. That would be a first.
Hide your kids, I mean, record all of them.
Dan? Oh, just the ones in this room or elsewhere?
Just the one, just
These. Okay. Good.
Yeah.
Because I have my staff.
yeah,
Uh-huh. Will that be through the OAFP website? Great.
Sort of like the athlete when you hire a football team. Yeah, exactly. People into it. So a lot of times I'll have, we'll take a few minutes and talk a little bit about the team development measure. We don't really have time to do that this afternoon, but I wanted just to expose this to you. It's going to be published in Family Medicine here in about 3 or 4 months, and so you'll have that. But I also, you can find it on, and its scoring, and instructions in scoring on the www.teammeasure.org. So if you Google Team Measure, it will be #1 that comes up. And you can read about the development of the tool and how to score and some of the more nuances about that. But it's very strong, has a very strong psychometric properties. We've used it in literally thousands of individuals, staff, and it's included both, primarily, probably 3/4 of it's been outpatient staff, about 20% in inpatient units, and about 5 or 10% administrative teams have used it and found it to be helpful. And what we've discovered, is that the team development measure is scored on a 0 to 100 scale, and it seems to be developmental. And that most teams are down here sort of in the building stages 1 through 4, and they are building these sort of 4 attributes. So if you look at the items on the scale, they all fall within sort of these 4 attributes that are being measured. One is the cohesion. We talked a little bit about that, the importance of cohesion, which is really the social glue that brings people together. It's why your receptionists and your nurses get up out of bed each day and come to work there. It's why they come and have pizza with lunch together. So it's that cohesiveness is a key attribute for any team. That has to be present. It's probably the lowest. I mean, it's probably the thing that is there in virtually all practices. What's a little bit more complicated is really the communication attribute. And it's really the ability for team members to say what they really feel and think, to be able to deal with conflict in a really productive way. And what I would say, by far the majority of teams are kind of in the stage 3, stage 4, which is really the developing communication skills first, because you need to have really good communication before you can even start talking about roles and goals. You can have these honest discussions about who's in charge here, whose role is to do this or that, and that you need to have clearly defined roles and goals within the practice, and having good communication skills really helps develop that. And then the 4th is really team primacy, that it's really the accomplishments of the team is really what's important, and not the me. And so I want to just quickly go through each of those 4 attributes and talk about some interventions that you might do in your practice to help support that. So the social glue in terms of cohesion, one of the things is when you hire people, you need to know whether they'll be team players or not. So it's sort of this hiring for fit. And sometimes you'll maybe even do team interviews as opposed to one-on-one interviews. Keith, yes?
Yeah, we've always done that. You know, that way we get buy-in, and we also, kind of do team voting on who we're going to hire when we interview. We can't always get everybody in the room, but we try to get as many as possible.
Right. Right. So it's a really important part to help support the cohesion within the practice. Understanding individuals' passions. So we had a receptionist who was really passionate about making the waiting room a very welcoming, almost spiritual place for people when they came in. And we empowered her to go for it. And so she developed, you had coffee, tea, but she also developed a library where patients could come in and take books, and people would do a book exchange. The magazines were always up to date. You never had a magazine that was beyond the current. But really understanding what it is that people come to work for. And then helping your job as leaders and in the team is helping support them to do that. Using the we, so language is really important. So using the we language and not the me language is what it's our patients, it's not my patient. John Saltz talked a little bit about that this morning. About it's not Saltz's patient, it's our patient, it's my patient, or it's, I'm your nurse. I'm not Dr. Saltz's nurse. Okay, it's our patient, our practice, and what we did in our practice is that we talked about this. We were explicit about this in our discussions, and that we gave each other permission that if we caught ourselves saying Dr. Stock's patient or it's my patient, that it was okay to correct it. Oh, you mean our patient? So we got people to start thinking about that. Communication. So we did some workshops. We took some time actually to develop some of the communication skills within our practice. There are a number of ways. I don't have time. That's kind of more advanced, some of the more advanced team discussions. We do a lot of practice of the communication through our huddles. And again, that's a good way that when you're thinking about doing your huddles, thinking about how you communicate with each other. And then as a leader, it's important for you to model the kind of communication that you expect people to have within the practice. Building the team roles and goals, having the staff actually write their roles, what they think they should be doing, and sharing that with everybody else. That's a really interesting exercise. Rick, I think you were just sharing with me about how difficult that was to write for some people to write that, and you begin to have that discussion as a group about what your role is in the practice. Clinical process, how many people have been doing flow charting or begin to do process mapping, flow charting to develop their medical homes? So that's a good way of not only looking at how you're doing your diabetes management or your process for doing immunizations within the practice. There's also a good way of understanding whose role it is to pay attention to that and being really explicit about who's accountable. Okay, and that's again clarifying roles and the goals in the practice. And then finally, looking for ways to really promote the team primacy is understanding, everybody should understand the mission. So it's like, Lyndon Johnson, you guys have probably all heard this story before, but he went to, in '68 when he went to Cape Canaveral, after they were about ready to send a man to the moon. He asked the janitor, he was walking down the hallway or whatever and ran into the janitor and he goes, "Oh, what's your job here?" And the guy looked up and he said, "My job is to put a guy on the moon." Okay? It's the idea that we're all doing the same thing and that they understand what that is. And that's important for your staff and to get that kind of buy-in. And being transparent with your staff about your outcomes. They should know what your mammogram rate is or your immunization rate is. Your receptionists need to know this as much as your MA and your doc. So being transparent. So I'm going to show you here some data that this was actually back in 2003. This is a team, this is the 0 to 100 scale. The stages from no team to the best teams at sliced bread. Each of these are one staff person. So each of the blue blocks. So you can see at the baseline here, we have somebody down here who thinks they're not practicing in a team at all. Okay? And you have somebody up here who thinks this is the greatest team. All within the same practice. So the point here is that your perception or the perceptions of the staff about whether there's a team there or not is going to be broad. All right? And part of the job is for you to narrow that variability. Okay? So you're going to have so we provided them the information from the team development measure. They had a discussion about it, and they discussed which are the ones, what one or two items in the measure they really wanted to work on. And so 4 months later, we retested them. And you can see, if you took the average of all of them, the average didn't change. But what did change was that the variability. Everybody got on the same page. And what we've discovered with this is that until everybody gets on the same page about what we're talking about with teams, they can't really move up the developmental ladder. All right? They'll go up, they'll move up together over time. But one of the critical pieces is understanding that. And so one of the tools that we use that I shared with you, there's a handout back there. It's called the Principles of Successful Teamwork and Team Competencies. There are 8 of them, and they came out of work that was done at Rush University at their geriatric care there in the mid-1990s or late 1990s. But we used this actually in our team meetings for a number of meetings, and we addressed each one of them individually at each meeting. So we didn't go through the whole thing, but we had one of the staff folks read it, and then they had a discussion about the team should have explicitly stated team goals. So we just spent the time talking about, okay, what are our goals here? What are we supposed to be accomplishing here? The team must have tools or strategies for effective management of conflict. Okay, let's talk about how we handle conflict in this practice. Is it healthy, is it not healthy, or whatever. So you can take so we took each one of them and actually talked through it, and then began to sort of brainstorm about what we could be doing in our practice that would make that better. So this is 42 clinics. You can see that even across clinics, there's a great variability in terms of how much how much of those attributes are present in those teams. And so we looked at the team development measure, and we asked the question, okay, of all those 31 items, which one of them was the best predictor of whether there was a team in that practice or not? And what do you think it was? Which one? Which item?
Communication.
Communication? I'm not sure. Okay. We have a communication vote. Which one? Anybody else? Huh?
Stated explicit goals.
Stated explicit goals. Okay. Well, let me show you.
Clearly 23.
3.
So it is, regardless of the topic, communication between the people in my work unit and department is direct, truthful, respectful, and positive. That is the best predictor of whether there is a team present or not. Of all 42 clinics. In terms of organizational health, we found that those practices that were high in team were a much more satisfied group of folks, of staff. That they're on a scale of 0 to 100. The yellow block were like all clinics. The blue or purple there were clinics that had high teamness scores. When you asked patients, the best predictor from the patient's perspective of whether their care, they were overall satisfied with their care, was their positive attribution to the teamwork of the clinic staff who took care of you during your visit. That was the best predictor of whether they were satisfied in general. We talked a little bit about the worksheet. There's a worksheet here that goes along with that we've developed along with the team development measure. What it does is it helps you begin to look at and focus on the items that you want to work on in your practice. And what I would recommend that if you use this in your practice, that you're going to find that a lot of your staff you're all going to agree on a certain number of these items, and there are going to be some items that nobody's going to agree on. The items you want to work on are the ones in the middle, the ones where half of the people in the room think this is great, it works, and the other half says it's not present. What you need to do is get them all on the same page. Okay? Those are the 2 to 3 items that you need to work on first, not the ones way at the other end that everybody disagrees or agrees is not present. Okay? And that what this tool does is help you put down into words the kinds of interventions, who's accountable, etc. About that. Now, I'm at the end of time here. I think there are a lot of important team issues. I'll just put these up here. Including how do you deal with conflict in your practice? What do you do with the non-team player, whether one of your partners or whatever doesn't want to play with teams? I've had physicians leave our practice who this was not what they signed up for. They wanted just to see patients, and so how do you deal with that? And particularly out in practices where it's hard enough to hire physicians. Leadership, you've got formal leadership in all your practices, but you also have informal leadership. You've got that nurse or whoever, receptionist, who really is in charge. and how do you bring them on board? So and where do families and patients fit in all of this? Do you have patient advisory councils? Do you have a way in which patients can connect to the practice in a certain way? So I'm just going to leave with you that the ideas here, kind of my final thoughts, is that teams just don't happen if we just get the right computer system, or if we hire the right people and we develop the right roles, and get a care coordinator or a behavioralist in the practice. That's not necessarily going to make you a team. Okay, that it really does take practice. It takes some thoughtful training about that. Physician leadership is critical to this. I've not seen practices that didn't have a very strong either physician or clinician champion that really was like a dog with a bone with this idea. It requires it's a 24/7, 365, okay? It's not a workshop. This is not, I'm not going to make you guys all into team players. And what we discovered is actually took about 2 years before the practices really were able to grab a hold of this. But it is very rewarding once they do, because you can pretty much put anything in front of them, any chronic disease du jour, and they'll figure it out on how to improve it. It really is pretty remarkable, and you get better outcomes. So I'll just stop there. And are there any questions or thoughts? Anybody want to share anything? Yeah. Rick?
I just one comment about physicians and leadership, and would be to challenge you a little bit on the fact that the physician has to be the leader.
Mm-hmm.
That I think that I've worked with very strong people who were great leaders that weren't physicians.
Okay.
And at least in my opinion, I tried to encourage everyone to have a role in leadership somewhere within the team.
And I think that those are the teams that are the strongest, are the ones where the leadership of the team we're encouraging everybody to be a leader. And that's certainly my philosophy too, is that we're basically all leaders.
That one of the biggest challenges I've had in the team is getting the other team members to make decisions as opposed to turning to me as the physician for the decision, regardless of how trivial.
Okay. Other thoughts or questions?
What are the outcomes needed?
Yeah, great question. What are the outcomes? So almost all the studies are observational studies. If you look at the patient safety literature, most of the hospital safety literature, and particularly in the ICU, L&D, and most of that, where they implemented a lot of some of these attributes, you'll find that patient safety improved. Okay. If on the outpatient side, it's very solid data, and in fact, that's one of the areas that I'm interested in terms of how do practices that are high on the teamness score have better outcomes. Actually, nobody's ever really done that work.
Better patient satisfaction.
Better patient satisfaction, but in terms of looking at better preventive medicine, prevention scores, and so on, it's been almost all, it's all been observational. Nobody's ever done any randomized controlled trial of practices with no teamness compared to practices with very high teamness. What do they look like? And in fact, there's currently a AHRQ expert panel steering committee, of which I'm sitting on, that is currently developing measures and for team-based care that is we probably won't get our report out until the end of this year. But it's an issue that's out there that AHRQ and the feds have identified as an issue, is that we need better outcome data and better measures to measure what is team-based care. Yeah.
Have you looked at all at, or are you familiar with trauma-informed organizational structure? Which in this case, and if you're not this time, we can talk about it later, I don't want to take up the time, but if you have, I'm just curious, for teams that aren't working, if you're looking at why that is.
Yeah, no, I'm not. Trauma, are you talking about like ED trauma, physical trauma, or are you talking about other kind of
No,
trauma?
if there's just a particular type of kind of, viewing an organizational structure
Mhm.
from a trauma-informed perspective. I
Yeah,
wanted to do
no,
that.
I know that. Other thoughts or comments? All right, well, that's all I had for you. Thank you for your time.